We will study about cardiovascular disease, how to examine, and also will discuss some important cardiac diseases so that you can face the questions of the examiners in your, if there is a cardiovascular system. Also it is for your knowledge. So to start with, cardiovascular disease examination, cardiac examination purpose. You know that all systems we examine as inspection, palpation, percussion and auscultation. So if you want to watch it well, come forward, or if you feel comfortable, be there, no problem. So examinations come with a inspection. What we see in yesterday in your previous class, we have discussed about JVP, about pulse, everything. But about the proper cardiovascular system, for inspection you will have to see something. Number one is inspection means what you are seeing in your bare eye. You are not touching the patient, but by watching the precordium and the chest and also the back, chest and the back, what you can see about the disease. One is apical impulse. Apical impulse is the most definite visible impulse at the precordium, at the apical area. The apical area is around the midclavicular line and the 5th, 6th place. Actual place you cannot determine, because unless you are allowed to palpate, you cannot determine the costal space. So don't say it is in the 5th intercostal space or in the 6th intercostal space, because it is a finding in the inspection. Unless you are allowed to palpate the chest, you cannot say which intercostal space it is. So on inspection you will say there is a visible impulse in the precordium, most likely to be apical impulse. At what place you can determine it is in the midclavicular line, away from the sternum or inside the from the sternum, that you can do. But definite intercostal space and away from the midclavicular line, it is not possible to say by inspection only. It is a what you see, what you watch in the apical impulse. Then apical impulse, if the left ventricular, if there is enlargement, apical impulse may be down and out. You know that. But on palpation, normal apex, when you palpate, you determine the confirm it. But before you are allowed to palpate, you cannot confirm. So say it is a apical, probably it is a apical, is the most visible definite pulsation in the precordium. So it is apical impulse, most likely. Then if you are allowed to palpate, then only you can determine which space it is there. If it is, you know that if it is left ventricular enlargement, it will be down and out, and it is right ventricular enlargement, it will be out only, not down, and it may be in normal position. So 3 positions are we determined, whether it is a normal position, or it is a down and out, or it is a out. Or if it is, if it is a very rare cases, if there is dextrocardia, then it may be on the right side, not in the left side, in rarest rare cases. If there is dextrocardia, the apical impulse, visible impulse will be on the right side, that you know. So these things we see in the apical impulse. What we see others? Some parasternal pulsation. Parasternal. We also called it a lift or heave. Lift. Parasternal lift. Parasternal lift, or you can tell it is a heave. Parasternal lift or heave, that is usually a visible pulsation seen in the left parasternal region. In left parasternal region, there is a visible pulsation, maybe due to right ventricular enlargement. It is usually due to right ventricular enlargement. You know what are the causes of right ventricular enlargement? Any chamber of the heart will enlarge when there is a obstruction or resistance in its outflow tract. So, pulmonary tract is the right ventricular outflow tract. So, if there is a pulmonary hypertension or pulmonary stenosis, the right ventricle will enlarge. In that case, or the right ventricle is enlarged by back pressure of the, suppose there is a left atrium enlargement, pressure goes to the pulmonary bed. Pulmonary bed again this enlargement of the right ventricle. In that case also there will be parasternal heave. Any parasternal heave indicates there is a right ventricular enlargement is there. And second pulsation may be visible in the pulmonary area. If there is a severe pulmonary hypertension, there can be a visible visible impulse in the pulmonary area. In the pulmonary area, you can guess it is a pulmonary area, but you cannot definitely tell unless you are allowed to palpate, because pulmonary area is the left second intercostal space. If you are allowed to palpate, then only you can say, or you can say there is a visible impulse in the base of the heart or the pulmonary area. That you can say. In the pulmonary area, visible pulsation, maybe in severe hypertension, you can see there is a visible pulsation in the pulmonary area if there is severe hypertension. Fourth visible pulsation may be in the parasternal. I have told you it is on the left side of the sternum, but similar impulse may be seen in the right side of the sternum. Right side of the sternum. If it is seen on the right side of the sternum, it is usually due to right atrial enlargement. It is due to if there is huge right atrial enlargement, there is a huge right atrial enlargement occurs in Epstein's anomaly. So, several other diseases where there is huge right atrial enlargement, you can get a right parasternal pulsation. Or if there is a aortic aneurysm, that arch of the aorta go like this. If there is an aneurysm in the arch of the aorta, you can see a visible pulsation in the right side of the sternum. Fifth, there will be visible pulsation in the epigastrium. You are watching the patient. You can see the epigastrium and suprasternal notch also. So, if there is a visible pulsation in the epigastrium, it may be normally found in children and thin-built adult. But abnormally it can be also found due to right ventricular enlargement, or again due to abdominal aorta aneurysm. Visible pulsation in the epigastrium. That is maybe very prominent finding when you watch the patients. If you see, you should mention in your inspection. There is a visible pulsation in the epigastrium. What are the causes? Sir, it may be normally occurs in the thin-built person, or if there is abdominal aorta aneurysm or right ventricular enlargement, we can get a visible pulsation in the epigastrium. Similarly, a visible pulsation may be seen in this is epigastrium, or visible pulsation may be seen in the suprasternal region. Here, suprasternal region, there will be visible pulsations. It indicates there is a hyperdynamic circulatory state. Where there is hyperdynamic circulatory state, it is a high cardiac output state. High cardiac output state is a hyperdynamic circulatory state. Several conditions occurs there, like your aortic incompetence is a hyperdynamic circulatory state. Like thyrotoxicosis is the hyperdynamic circulatory state, and also your severe anemia can be a hyperdynamic circulatory state, or there is aortovenous anastomosis. This is a hyperdynamic circulatory states. See all these hyperdynamic circulatory states, you may see a pulsation in the suprasternal notch. So, it completes all the visible pulsations. To summarize, the apical impulse, left parasternal heave, right parasternal pulsations. You can say it is a left parasternal heave, right side pulmonary, maybe right side of the sternum, in the pulmonary area, and also in the epigastrium. These are inspectory finding. But don't also forget to inspect the back of the patient also. Where you can get a back in the back. This is the front patient. But the inspection is not complete in respiratory or in cardiovascular system unless you inspect the back of the patient. What to see in the back? First to see the spine, whether it is aligned or not, if there is any kyphosis or scoliosis. Scoliosis, it is a lateral bending of the spine, lateral bending. And kyphosis, there is a forward bending. Several abnormalities of the lung and the cardiac systems are associated with this kyphosis and scoliosis. A severe scoliosis, if the vertebral column is shifted to the left side curvature like this, then it can draw the mediastinum with it. So there is a mediastinal shift with severe scoliosis, and this kyphosis is also associated with many diseases, cardiovascular disease. We just see there is any skeletal abnormality. Patient may have had a history of tuberculosis in the childhood and got the kyphosis. The spine is prominent and curvature outwards. So these things can be there. If it is there, you will have to mention. If it is not there, no matter. But if it is there, you do not mention it, then it is a problem. It is obvious. You can see the abnormality in the spine, in your back. These actually complications, and also in the back, very important, below the scapula, scapular angle, the scapula is there in the back. You can palpate the scapula, and the scapular angle in the lower end of the scapula is situated, is almost coincide with the T7 spine. And is the 7th thoracic spine. So below the scapula, there may be some pulsation. It occurs when there is it occurs in coarctation of aorta. In coarctation of aorta, the intercostal arteries are passing huge amount of blood, because there is a obstruction in the aorta. So intercostal arteries are tortuous, and also they passes a huge amount of blood. That's why there will be a pulsation in the below the angle of the scapula. This is also called Sujman sign. Sujman sign. Sujman. This is also called Sujman sign. And in our auscultation, we will also discuss, it may be associated with a murmur also. This is also called a Sujman's murmur. Anyway, so these findings are found in when you get a coarctation of aorta. Apart from visible pulsation and skeletal abnormalities, we should see also the visible veins. Then apical inspection, we got the apical impulse, etc. And also there is whether there is any prominent veins, visible veins. Visible veins in the front of the chest and also in the back of the chest. Visible veins, why they occur? They becomes prominent if there is an obstruction in the superior vena cava or there is an obstruction in the inferior vena cava. If there is obstruction of superior vena cava, what will happen? All bloods from they cannot drain into the right atrium. So all the veins will try to drain to the iliac veins and femoral veins. And from femoral veins, they can go through inferior vena cava, they can drain. So their motto is how to drain into the heart. So in case of superior vena cava obstruction, the blood flow in the veins will be from upwards to down. But opposite in the inferior vena cava obstruction. If there is inferior vena cava obstruction, what the iliac veins and other they cannot drain through the inferior vena cava. So all they will drain through the anastomosis in the chest wall and abdomen. They will drain into the superior vena cava. So in that case, there will be venous engorgement, but filling will be from below to up. You know how to see the filling of a vessel vein. Just put 2 fingers in the vein and separate squeeze the blood from it, and if you lift the one finger, it will, if it is filling from here to here, it will be filled up. But if you place these things up, if it is from here to here the blood is flowing, then it will be filled up. So after squeezing, you lift one finger and see which way the blood is going. That is the way of watching a visible veins in which way it is draining. So these and if there is any accessory nipples and ulcers, etc., that is almost visible, we should mention. This is all about inspection of the heart. Now come to the palpation. Before going to palpation, you should have a clear idea about what are some positions in the heart, anatomical positions in the heart. Before going to palpation, because we palpate according to the area. There are several areas. No? There is a mitral area, pulmonary area, aortic area, and tricuspid area. What is the mitral area? You know, mitral area is usually in the fifth intercostal space, half inch inside the mid clavicular line. There is a clavicle, you know, the collarbone clavicle. There is a mid clavicular point. If you go downwards, it is a mid clavicular line. It meets with the mid inguinal point below. So it is a mid clavicular line. The apex is usually in the if unless it is dextrocardia, apex will be in the left side in the half inch inside the mid clavicular line. So it is the normal area of the mitral. This is the normal mitral area. But don't confuse it with the apical area. Apical area and mitral area are different because apical area is the area where the apex is. Apex may be down and out, may be out. So this is not the apical area. This is an anatomical fixed position. This is a mitral area. This is a half inch mid clavicular line, half inch inside the mid clavicular line in the fifth intercostal space. That is the apical area. Now there are other areas also, like pulmonary area. Pulmonary area, you know, it is a left second intercostal space by the side of the sternum. There is a pulmonary area. And aortic area is the same. It is the right side, second intercostal space. This is the aortic area. And there is also one area, tricuspid area. It is a below lower end of the sternum. In the left end of the sternum, lower end, there is a tricuspid area. And another area also sometimes used is called neo-aortic area, or also called Arf's point. That is the left third intercostal space. It is left third intercostal space is kept because some of the aortic murmurs are best heard not in the aortic area, but in the neo-aortic area or the left third intercostal space. It is also called the Arf's point. So these are the areas in the heart. When you are doing a palpation, palpating the heart, you will have to palpate according to the areas. What you will see in the first, you see the palpate, you see the apex. Palpation, first you see the apex. So what you should mention, what you have watched in the your inspection, you will have to confirm. You will have to confirm it in your palpation. If the apex is in the fifth intercostal space, in a half inch, it will be inside the mid clavicular line, or it is the sixth intercostal space, half inch away the mid clavicular line. That means you are telling it is the left ventricle is enlarged because it is in the sixth space, it is down, and it is also out because in the half inch away the mid clavicular line. So it is down and out, it is a left ventricular enlargement. But if you say it is the apex is at the fifth intercostal space, half inch away the mid clavicular line, that means you are meaning that it is not down, but it is out only because it is in the fifth space itself. So it is only, if it is only out, it indicates it is usually it is a right ventricular enlargement. So you will have to explain the apex is what it is a sixth intercostal space, half inch away the mid clavicular line. What does it mean? It means there is a left ventricular enlargement. Anyway, so apex, you will have to see the first, you will have to mention the site of the apex. What is the site? First. Second, you have to mention the character of the apex. Character. What we see in the character? The amount of lifting of your finger. Amount of lifting of your finger in the apical area. Several terms are used. Most common terms used is tapping. Tapping. Tapping apex means it is just coming, you are touching your finger, the apex is touching your finger and going out, going off your finger very quickly. It is touching and going off your finger very quickly. So it is called tapping. It occurs in mitral stenosis. So if it is a case of pure mitral stenosis, the character apex should be tapping. It is very quickly touching your finger and going away. But it may be some other way also. It may be a forceful. So naturally, the tapping is not forceful. It is not forceful, but it may be forceful, ill-sustained. Ill-sustained. Forceful, ill-sustained. When it is forceful but not staying for a long time. How it can occur? It occurs if the left ventricle has some other outflow to empty the blood. That is why it is not ill sustained. Why it is forceful? Because the left ventricle is dealing with more blood. You know, in mitral stenosis, very little blood is coming to the left ventricle because of mitral stenosis. Most of the blood is stuck into the left atrium. It is not allowed. It is not coming to the left ventricle. So, in mitral stenosis, there is no chance of left ventricular enlargement or anything. If it is a pure mitral stenosis, there is no chance of left ventricular enlargement or anything, left ventricular features, because left ventricle is dealing with less blood. But here, the left ventricle is dealing with more blood, but there is way to empty the blood to the other places. Like for forceful ill sustained, maybe in the case of suppose the blood is coming to the left ventricle is contracting and it is going to the aorta and VSD. There may be aortic incompetence, or if there is a mitral incompetence, or there is VSD. What will happen? In these cases, left ventricle has the conduit to empty the blood. That is particularly mitral incompetence and VSD. So, why forceful ill sustained occur? It will in mitral incompetence or VSD. Because left ventricle will empty quickly, but it is forceful because it is dealing with more blood. Another character of the apex is forceful but well sustained. Well sustained. Well sustained. Previously it was called the heaving apex. Heaving. Forceful, well sustained. But here it is forceful, but staying for a long time. So naturally, you can guess how it occurs if the left ventricle is getting some obstruction to empty the blood. There will be, if there is obstruction, the forward obstruction. So it is enlarged because of it is working more, and there is obstruction outflow in the outflow tract. So there is it is sustaining for a long time. So forceful, well sustained. So you can guess where it can occur. Can you guess it? Where it can occur? Where the left ventricle has forward obstruction? In which conditions the left ventricle has forward obstruction? In aortic stenosis. In aortic stenosis. Aortic stenosis. It is forceful, well sustained. And also another condition, can you see it? Can you see it? Anyway, so, and another condition is called HOCM, or hypertrophic cardiomyopathy. This is a congenital condition where there is some increased muscle mass in the left ventricular outflow. That is called HOCM, hypertrophic osteotic cardiomyopathy. Quite common. So, there is a forceful aspect whether it is aortic stenosis or maybe bicuspid aortic valve. It is also causing aortic stenosis. And HOCM, the hypertrophic obstructive cardiomyopathy. In these conditions, there may be heaving apical lymphs. And forward obstruction may be there if there is another conditions like hypertension. Hypertension, there is a resistance in the aorta, so left ventricle will take more time to empty. When there is left ventricle taking more time to empty, it is called forceful, well sustained, or it is called also heaving apical impulse. So these things happen, and also it can also occur in coarctation of aorta. In coarctation, there is an obstruction in the aorta. So left ventricle will take more time to empty its blood. So in this, there is a forceful, well sustained. This is about character of the. This is about character. So in apex, we have completed this site where it is, and it is a character. Next thing is whether there is any associated with thrill. Thrill, you know, if you palpate the area with your palm, you will get a purring sound, like the sound you can feel in a the purring cat, or like that. The cat is purring. There is a sound called purring sound in the area wise. So there may be thrill. Similarly, thrill may be systolic, may be diastolic. If that thrill is coinciding with your apex, it is systolic. If it is not coinciding with your apex, coming before the apex, then it is diastolic. So usually all organic murmurs may be associated with a thrill, but remember, no functional murmur is associated with thrill. Only organic murmurs. What is the difference between organic murmur and a functional murmur? Organic murmur, there is a anatomical obstruction of in the area, and in functional murmur there is no obstruction, but there is increased flow. That's why there is a relative obstruction. The obstruction can be two way. Either obstruction, mechanical obstruction, or it may be just due to excessive flow there is obstruction. So when there is excessive flow, there is obstruction, we call it a functional murmur. Remember, no functional murmur is associated with thrill. We get functional murmurs in many conditions like ASD, like anemia, we get a functional murmur. In case of ASD, there is the aperture in the septum, atrial septum, but we don't get the murmur due to flow in the septum, but we get the murmur due to excessive flow in the pulmonary artery. So we get a pulmonary flow murmur in ASD. There is a flow murmur that should not be associated with thrill. But if it is a mitral stenosis, we know we get a diastolic murmur. That diastolic murmur may be associated with the thrill. It is a diastolic thrill. Or if it is a mitral incompetence, we get a systolic murmur that may be associated with a systolic thrill. If it is aortic stenosis, we get a systolic murmur is associated with a systolic thrill. If it is aortic incompetence, all these are anatomical lesions, mechanical obstructions, mechanical lesions. Aortic incompetence, we get a diastolic thrill. So murmur may be associated with the thrill. If it is an organic murmur, it should not be associated with the thrill when there is functional murmur. This is important. So you will have to mention all these things, whether there is any, what is the site of the in palpation, and whether there is thrill. Second, you get it? The ticker. Second, we have mentioned about parasternal lift. We have in our BRI, you have seen that there is a left parasternal lift or heave. Same lift is due to just right ventricular enlargement, and heave sometimes we call it when there is right ventricular obstruction, outflow obstruction. But it is only there is enlargement, but no obstruction, we can get a lift or heave, whatever it may be. That is an important thing. But if there is a pulsation, you should palpate it by your this ulnar end of your finger, hand like this. You cannot palpate the hip with your palm, but only in the side of your hand. Put a side of your hand in the left side of the sternum and feel whether there is any lift on your hand. It may not be visible. You may get it on palpation only. It was not visible in your inspection, but on palpation you get a parasternal lift or heave. It indicates there is right ventricular either enlargement or we call it as either pressure overload. Overload may be pressure overload or volume overload. A cavity of the heart may be overloaded by two ways. Either there is pressure overload. Pressure overload means there is forward obstruction, or there is volume overload. It is dealing with more blood. So somebody use it as a parasternal heave when there is pressure overload. There is a pressure overload, right ventricular outflow obstruction, and similarly, if it is a lift, then it is the right ventricular not the outflow obstruction only. There is enlargement. Anyway, so pressure overload, volume overload. It doesn't matter. But pulmonary area, if there is a in palpation, pulmonary area, if you see a visible pulsation in the pulmonary area, means the pulmonary hypertension is there. Pulmonary hypertension means there is a very loud P2. Very loud P2. If the visible pulsation is visible in the pulmonary area, means you are dealing with a patient with very loud, very severe pulmonary hypertension, and that patient should have a very loud P2, and that P2 may be palpable also. So it may be, you may call it as a palpable P2. This is a palpatory finding. You may call it as a palpatory P2. Similarly, you go to the aortic area. If it is a systolic murmur, may be associated with the systolic thrill, or a diastolic murmur may be associated with the diastolic thrill. You know, aortic stenosis, there is a systolic murmur, and aortic incompetence, there is a diastolic murmur. Same murmurs may be associated with thrill. Similarly, the tricuspid incompetence and tricuspid stenosis also. Tricuspid stenosis, like mitral stenosis, will give a diastolic murmur in the tricuspid area, and tricuspid incompetence will give a systolic murmur in the tricuspid area. That area may be associated with thrill. These are the almost these are palpatory findings. Now we get sometimes in rare cases there may be a pulmonary knock, like your pulmonary knock means constrictive pericarditis. In constrictive pericarditis, there may be this pericardial knock. One sound we call it a pericardial knock. Due to sudden stretching of the pericardium, there is a click sound. Sometimes this pericardial knock may be palpable, but your palpatory finding must corroborate with your auscultatory finding. Don't tell two things. Palpatory finding one thing, and if, I have already well discussed with this, the palpatory, what is the palpatory finding and what is the auscultatory finding along with it. Don't mix it up. Either if you can tell it is a pulmonary palpation, I have got the P2, palpable P2, and also in auscultation you are not telling it is a P2 is loud, then it is when you have not understood the things, hemodynamics. So these things are there. So this is palpation. And in inspection also there is one, if there is aortic incompetence, in inspection we can see the very prominent carotid artery impulse. Carotid is also called dancing carotid. If it is there, you should mention, yes sir, patient is a severe aortic incompetence, we are getting a dancing carotid. Means carotid arteries are almost just jumping in severe aortic incompetence. That is the inspectory finding. So many things are there. When you go through the individual diseases, you will get that things. Anyway, so there is palpation we have already completed, we can come to auscultation. Auscultation. In auscultation, we also do the same thing according to the areas. First in the mitral area, then your parasternal region, but pulmonary area, then aortic area and tricuspid area. According to that, you go through your auscultation. And also you should auscultate some amount in the back, and also from radiation of the murmur, that I will come in shortly, that you will have to auscultate. So what you see in the mitral area auscultation, the most prominent sound we get is S1, no? S1. This S1 we get a most prominent in the apical, in your mitral area. S1. S1 when it will be loud, then S1 will be, when it will be loud, when it will be muffled. There's two questions. When the S1 will listen it very loudly, and when it will be muffled. S1, and in that class I have told you that S1 is associated with the C wave, no? C wave in the JVP. Anyway, the positive, this is one positive C wave. This is positive C wave. Anyway, whatever it may be, JVP, we are not discussing it. JVP, you have to know it. To understand the hemodynamics of the heart, you should coincide this cardiac cycle, three things. One is the heart sounds, diastole, systole. It is coincidence with the JVP, and it is coincidence with the ECG. If you are interested, you can study this coincidence. When there is S1, what will be in the JVP? When there is diastole, what will be in the JVP? When there is systole, why coincides with the JVP, and how it coincides with the ECG also. That you should understand. Anyway, so for our discussion today, S1 will be loud or very loud. S1 will be loud in case of a simple reason like hypertension. S1 will be loud. But for our examination purpose, we have to mention S1 will be loud in mitral stenosis. S1 will be loud in mitral stenosis. S1 has also got two components, that is a mitral valve one component and tricuspid valve one component, but we cannot separate it clinically, this mitral component, tricuspid component, unless there is some diseases we can separate it. But suppose there is a right bundle branch block, and the high pressure zone, the mitral valve is a high pressure zone and the tricuspid is a low pressure zone. The high pressure zone will close first and the low pressure zone will close second. So S1 also has a two component, like your mitral component and tricuspid component, but you cannot separate it. So unless it is very much wide apart. So S1. After that S1, what will start? Systole. This will systole start, no? Then there will be S2. You know S2 has two component, no? S2 has two component. S2 has two component. What? First come A2 and it is come P2. Aortic valve and pulmonary valve, they close, two sounds are there, but we listen it as a one single heart sound, second heart sound. But second heart sound splitting is important because it is audible, it is appreciable. You can pick it up through your stethoscope when you listen carefully. So this is important. A2 and P2. This is second heart sound. Again, there will be diastole and there will be first heart sound. Again S1. So in apical area, if you say prominent S1 means it is a mitral stenosis, maybe there, mitral stenosis. But this prominent S1 mitral stenosis may not be the first heart sound may not be very prominent if there is calcification in the mitral valve. Because if there is calcification or there is a pliability of the valve is lost due to some fibrosis in the chorda tendineae, then this may not be found. So a first heart sound loud in the mitral stenosis means the valve is very healthy. It is pliable and non-calcified. Got it? Right. And it is muffled in mitral incompetence. S1 will be muffled in mitral incompetence. Muffled means the intensity is low. It is in mitral incompetence. Right. But in case of mitral stenosis, if you get a muffled S1, if you tell it is an S1, I cannot audit. It is a case of mitral stenosis, but I cannot hear the S1. I cannot auscultate the diastolic murmur, and it is a mid-diastolic rumbling murmur. Everything character is there, like mitral stenosis, but I cannot hear the first heart sound clearly. You are meaning that either the valve is not pliable or there is mitral incompetence associated. Got it, no? So either you tell it is a first heart sound is very much loud, sir, mitral stenosis, it fits with mitral sound. But if the first heart sound is not very loud, then you are meaning whether either the valve is calcified, not pliable, or there is mitral incompetence may be associated. Anyway, so this is diastole. This thing is systole. After that, you see the S2. S2 means there is an aortic component and pulmonary component. I have told you. S2 is normally, unless there is pulmonary hypertension. S2 is very loud. I have told it very repeatedly. The S2 is very loud in pulmonary hypertension. That is, the pulmonary component will be loud, not aortic component. That is, the pulmonary component will be loud and pulmonary hypertension. So if there is no pulmonary hypertension, usually S2 is not very much audible in aortic in apical area or mitral area. So if you say that P2 is very much audible in mitral area, in the back of the mind, the examiners will take it granted that you are going to tell a pulmonary hypertension. Either you tell, sir, S1 is audible, S2 audible, S2 is not very much well audible. Means you are not meaning that there is pulmonary hypertension. So if there is severe pulmonary hypertension, only S2 will be audible in the mitral area. Otherwise, S2 will be very much audible in normal condition in pulmonary area. It should be appreciable, the aortic component or the pulmonary component. These two components you should appreciate in the pulmonary area. Best area to hear the second heart sound is the pulmonary area. Here the aortic component and pulmonary component you can separate. So the S2 is there. Then what will be in the mitral stenosis? What will happen? There is some gap. There will be, after that there will be in the mitral stenosis there is an opening snap. In mitral stenosis what you get? There is an opening. It is an auscultatory finding. You will get an opening snap. So there are heart sounds you are first watching. What you have watched is the hub S2 and S2. Opening snap also comes in the heart sound. If it is there, in case of we get it in a mitral stenosis, not very severe stenosis, in a moderate stenosis, we get an opening snap. Opening snap, if the examiner tell you describe the heart sounds, when his meaning about you describe the S1, you describe the S2, and if there is opening snap, you describe it. Why this opening snap? Opening snap is due to opening of the mitral valve. And after opening snap, get a S3. S3, huh? S3. Why S3? S3 is associated with the rapid filling. It is not the last rapid filling phase. It is the early rapid filling phase of the ventricle. Where the ventricle starts dilating and it is forcefully dilating. Just dilatation starts and it is a forcefully dilating. It takes much amount of blood from the left atrium. The left ventricle is doing forcefully. The blood is sucking. It is diastole has started. Forceful diastole and it is blood is sucking from the left atrium. That gives a sound. That is a S3. That obviously it occurs in the early diastole. But never it is found in mitral stenosis. Because in mitral stenosis, left ventricle cannot suck blood. So why there will be S3? I have seen in an examination, probably you have seen some dadas has told us there is a S3. Yeah, all students are S3. No, S3 should not get in a mitral stenosis. Because the left ventricle cannot suck blood from the left atrium. So no S3. But very important for mitral incompetence. Similar in mitral incompetence, what will happen? The blood has come to the left ventricle. Again, it has gone to the left atrium, and when the left ventricle is pulling, it is pulling more blood from the left atrium. So S3 is usually found in a mitral incompetence, not in mitral stenosis. Probably I have explained to you why the S3 is found in mitral incompetence, not in mitral stenosis. Because it occurs in the early diastole. Then comes this S3 and opening snap. So diastole is a very interesting and eventful place. How it occurs. And I have told you about pericardial knock. Pericardial knock. Why it occurs? When there is a constrictive pericarditis, where the ventricle cannot, where the heart cannot dilate. And suddenly, when the bloods are coming, but heart cannot dilate because of constrictive pericarditis. There is an infection in the pericardium, usually maybe in tubercular, maybe viral. There is a constrictive pericarditis, usually in tubercular pericarditis. There is a constriction. Okay. Here you can get a pericardial knock. Pericardial knock. So all this come sequentially. What is your S2, then comes opening snap, then comes S3, then pericardial knock, if it is there. If it is constrictive pericarditis. If it is constrictive pericarditis, there is pericardial knock, it will be present in the diastole. It is the diastolic sound. And at the late part of the diastole, we get a S4. There is S4. So if you are asked to describe the heart sounds, means you have to describe S1, whether there is an S1 or not, whether there is an S2, whether there is an opening snap, whether there is an S3 or there is an S4. These all sounds you will have to tell. So S3 I have told you how it occurs. S4. S4 occurs in the last rapid filling phase. You know the cardiac cycle in the last, where there is atrial contraction. In the last rapid filling phase, what occurs? There is an active left atrial contraction. And the whole blood is coming to the left atrium suddenly. Here why the sound will occur? When the left ventricle cannot dilate. It has lost the capacity to dilate during the left atrial contraction. That is in the last rapid filling phase. Why it cannot dilate? Because it is disease, maybe cardiomyopathy, maybe some other disease, left ventricular failure, it cannot dilate. But it cannot accommodate the blood, the left atrial contracting forcefully in the last rapid filling phase. It cannot accommodate the blood. Therefore, there is sound in the S4. So why you will get the S4? The left ventricular failure, where the ventricle cannot dilate properly. Restrictive cardiomyopathy, where the left ventricle cannot dilate properly, and it cannot accommodate the blood during the last rapid filling phase of the left atrial contractions. So S4 is there. So this way you should describe the heart sounds. Then comes after the heart sounds, you get and also the adventitious sound S3, S4. After that, you have to describe the murmurs. Murmurs, you know, diastolic murmur and systolic murmur is there. So in case of mitral, there are several diseases that you should describe your murmur. In mitral stenosis, murmur will be mid-diastolic murmur. Here after that, pericardial knock is not there, S3 is not there. In mitral stenosis, and murmur will start from here. And S4 is also not there in mitral stenosis. S4 is not there. But S3 is S3 is usually found in mitral incompetence. It's a usual finding. But here there is a classical murmur of the mitral stenosis. What is murmur? There is a mid-diastolic rumbling murmur. This is a mid-diastolic, the diastole in the mid-diastole, rumbling murmur with a pre-systolic accentuation. The systole just before it, here again systole starts. So before systole there is an accentuation. So to describe the murmur of a mitral stenosis, what will be there? It is mid-diastolic, it is rumbling in quality, and there is pre-systolic accentuation. Because pre-systolic accentuation is associated with the last rapid filling, there is pre-systolic accentuation. This is the classical murmur, but it is not touching the S1. Not touching the next S1. It ends before the S1. So this is a classical murmur of mid-diastolic murmur, mitral stenosis. But in mitral incompetence, what we get? We get a pan-systolic murmur. In mitral and mitral stenosis also, what will be the other finding? Mitral stenosis is usually associated unless the patient is coming to the hospital, means the patient has some amount of pulmonary hypertension. Some amount of pulmonary hypertension means there should be features of pulmonary hypertension. I have already told you, there is right ventricular enlargement, loud P2. These are the features of pulmonary hypertension. That will be there. There will be loud P2. So, in the pulmonary hypertension when you there is a mid-diastolic rumbling murmur you have seen in the apex, that is gone. But pre-systolic accentuation will not be absent. Will be absent if there is atrial fibrillation, because I have told you it is due to active atrial contraction. So you can guess where when there is the active atrial contraction due to atrial fibrillation. In atrial fibrillation there is active atrial contraction. So there is no chance of getting this pre-systolic accentuation will not be there, and another sound will be not there. Which sound? S4. Because I have told you S4 is the last rapid filling phase due to atrial contraction. That will also be absent in atrial fibrillation. So because these sounds are depending on last rapid filling phase. So mid-diastolic rebound. And in pulmonary mitral stenosis, what you will get? This is a loud P2. And loud P2 means A to P2 gap will be increase in inspiration. So in inspiration, the P2 will be more delayed. A2 is first there, but P2 will be more delayed. Then you can appreciate in the more vividly in the pulmonary area. So tell the patient to take inspiration and see and auscultate the pulmonary area. You can watch the gapping of the A to P2 will be more, because in inspiration the right heart will get more blood, and more blood that will take more time to empty into the pulmonary artery, and the pulmonary component will be delayed. So A to P2 gap will increase. The P2 will be loud and A to P2 gap also increase. There is the pulmonary hypertension you will get in a mitral stenosis. Because mitral stenosis is a very common patients you get in your exam. So, and there will be also right ventricular enlargement. So, what you will get? You can get a parasternal heave. Now, I have told you right ventricular enlargement due to there is a pulmonary hypertension, there is right ventricular enlargement. So, there can be a parasternal heave. In mitral incompetence, what happens? In mitral incompetence, there is a pansystolic murmur. Murmur will be like this in mitral incompetence. There is a pansystolic murmur. It starts with the first heart sound and also end in the second heart sound. In apical area, usually it takes the first heart sound and second heart sound, both will be not very much well audible, because it is a pansystolic murmur. Audibility will be less. First heart sound and second heart sound will not be very much audible in mitral incompetence, because it is a pansystolic murmur. What is the cause of the pansystolic murmur in the apical area? And also, what is the pansystolic murmur? And one is mitral incompetence, pansystolic murmur. Other pansystolic murmur may be in VSD or PDA. VSD and PDA will also cause the pansystolic murmur. It covers the whole systole, and it takes the first sound and the second sound along with it. So both sounds are not very well audible, only the murmur is audible. And if it is a organic murmur, it may be associated with the thrill. Usually associated with the thrill. PDA, there is a patent ductus arteriosus. Patent ductus, there is a communication between the aorta and the pulmonary artery, and there is a continuous flow. PDA we get a continuous murmur. PDA initially the blood flow will be from aorta to pulmonary artery, and then pulmonary hypertension will be there. Then the flow will be both way. So we get a continuous murmur, both systole and diastole. And aortopulmonary window of aortoparathyroid also gives a continuous murmur. But in PDA there will be continuous. PSD there will be systolic murmur like this, and mitral incompetence there will be systolic murmur. What will we get in aortic stenosis? It a mid diastolic, aortic stenosis is a mid systolic murmur. In aortic stenosis murmur will be a diamond shaped murmur. No, this is a like that murmur. That is a then in aortic stenosis murmur, faster sound and second sound will be well audible because it is a mid systolic murmur, aortic stenosis. And aortic incompetence also, there is a early diastolic murmur. In aortic incompetence there will be early diastolic murmur. In aortic incompetence there will be early diastolic murmur. In VSD there will be systolic murmur, and in PDA there will be continuous murmur, systolic, diastolic both, also called machine murmur. The machine is going. And ASD, I have already told you what will happen in ASD. In ASD, the murmur is not for the flow of the blood, but as the blood from the left atrium goes to the right atrium, and the right atrium it will come to the right ventricle, and from the right ventricle goes to the pulmonary artery, and there is a huge amount of blood going to the pulmonary artery. That's why there is a pulmonary artery flow murmur. Usually, what you get is a pulmonary artery flow. We call it a flow murmur, and it is a functional murmur, not associated with thrill, but there is a systolic murmur in the pulmonary area. And in very important in case of ASD, there is a fixed split, fixed and wide split. S2 in case of ASD, S2 will be fixed and wide. Why wide? Because there is more flow of pulmonary blood, there is a more flow to the pulmonary area, pulmonary valve will close late, and there will be AT-P2 gap. AT-P2 gap, so there will be wide gap, wide gap of the S2. Wide gap as the S2 means AT-P2 gap is increasing. And why it is fixed? Because fixed means the blood, this gap, this AT-P2 split is hard in inspiration and expiration in both stages. That is fixed. Fixed means that if split should not, split I have already told you, in the inspiration there is a more flow of blood to the right ventricle, right atrium, and so a split should be hard in the inspiration, not in expiration, in the pulmonary area also. But if you had a split in the inspiration and expiration, both phases, then it is called a fixed split. Fixed split. It is hard in inspiration and expiration both. It is that is occurs in ASD, atrial septal defect. There is a fixed and wide split of the second order sounds. So this is about second order sounds and all murmurs. Okay, we completed today class. Next class will be on, I think next class will be on clinical aspect, and as we have done in the previous systems, we have discussed it in the theory, then we have done it in the practical. So I think next class will be on cardiovascular examination in a patient in the ward. Okay, so next class will be in the ward. We get a cardiovascular. If there is a cardiovascular case, we will take them. Other any patients, I will show you the examination, how these examinations, all these examinations are done. Inspection, palpation, percussion. Auscultation is usually not done in the cardiac cases. Not done, because if there is a embolus during percussion, you can dislodge it. That's why percussion is not allowed in cardiovascular disease. But it is important to mention that some things, like if the cardiac auscultation, if the cardiac shadow is the auscultation, there is a lung vesicular sound, and in the dull area is on the heart. If it is closed, then there is emphysema. In emphysema, the cardiac dullness will be less, but if it is more in pericardial effusion. And chest percussion only done in mediastinal widening cases. If there is a chance of mediastinal widening, we will have to do it. Otherwise, not done. Okay, thank you.